Thank you, Linda, and thanks everybody for coming along to this presentation. A bit of a change of pace. Thanks very much to Jackie and Susan for theirs. They've been such interesting presentations so far. And as Linda said, I'm in my second year at University of South Australia, and my research focuses on developing and implementing a nurse-led clinic. But I will pick up to start off with the terminology that Susan used in her presentation earlier, that it was a nurse-led collaborative care model, wasn't it? Yeah. So that'll just link into my presentation later, that terminology. So just sort of put that aside for the moment. So this is just an overview of the presentation that I'll be doing today. And first of all, I just want to give you a bit of context and a bit of background to the broader picture of the research that I'm doing, and then I'll move on to the systematic review, the process, and some preliminary findings. So the systematic review that I'm going to be talking about sits within a broader research project. And although my broader research focuses on people living with multimorbidity, you'll see further on that the systematic review that I'm going to be doing really focuses on chronic disease. And this is because multimorbidity, as you'll be aware, is a relatively new concept. The prevalence of it has really only been mapped in the past 10 to 15 years, and therefore there isn't a lot of evidence, particularly around nurse-led clinics and multimorbidity. Therefore, my systematic review focuses on chronic disease generally and nurse-led clinics. And I'm hoping to be able to extrapolate out some of those findings. So broadly, the research design and methodology, it will be is an action research project, and it's underpinned by a philosophy of pragmatism. And I've just got up there some of the data collection methods that I'm using. And it'll be a series of action research cycles. Kennison-McTaggart's model is going to be used, as you can see there. And the plan, act and observe, reflect, replan cycles will see the slow implementation of the nurse-led clinic. And along the way, data will be gathered through surveys, meetings, semi-structured interviews, a reflective journal, and medical case notes. So as the proposed nurse-led clinic will be providing services for people living with multimorbidity, I just want to talk about that a little bit firstly. And as you would all know and be well and truly familiar with, I'm sure, multimorbidity is defined as 2 or more chronic diseases in an individual. And in Australia, as you can see, 39% of people live with 3 or more chronic conditions, and 36% of people live with 2 or more. I kind of think I'm around the 3 mark, actually, it feels like at times. But anyway, and interestingly, it's not just older people that live with multimorbidity. It's a very complex situation to be in. And the sorts of people that I'm seeing as we go are like cancer survivors. They often go on to develop multimorbidity. HIV or Hep C survivors, and often that group of people can be more complicated as well. I've recently had the migrant services contact me about the refugees because they need interpreter services as well, and they have a lot of people with multimorbidity. And then there are younger adults with complex disability and multimorbidity, and where I am as well, we get the children transferring from the children's hospital into the adult sector, and that opens up a whole Pandora's box of complex health needs that need to be met in a very different way from what they're used to in the children's system. Excuse me. And then, of course, there are the older adults with complex chronic disease. So I think the complexity of this multimorbidity is really best described or illustrated by a case conference that I attended this week. We had 3 patients that were raised for discussion, and the first woman in there, we were just exploring the issues to see what sort of care she needed and what interventions would be as a result. And after much discussion, it was really unearthed that probably this woman's primary problem that we considered but hadn't been diagnosed or discussed with her was dementia or a cognition issue of some sort, with possibly health literacy issues. And the intervention for her would be that Caroline would come and assess her, the memory support clinic nurse, but we don't have Caroline in South Australia. So instead, we're going to have a neurogeriatric home assessment done with her. But that conversation will need to be started in some way with her. And I think that you're starting to see that this care conference was our discussion, but the patient wasn't there. So I just want you to hold on to that thought, because I will get to that later on. There was another gentleman who was discussed, and his issue really turned out to be one of chronic pain, and polypharmacy was an issue, and the intervention that he really needed was care coordination and pulling together all his issues and have those discussed and a care plan decided with him. And then the third person was a woman who had a background of spina bifida and complex care needs, and she had really recurrent UTIs and cellulitis that she was being admitted with like really fortnightly. So her escalation plan wasn't working, so she also needed a care plan worked out with her and issues. So this is just to illustrate that sort of background of multimorbidity. The second thing in terms of the background is the models of care. And a model of care is that approach to patient care that's grounded in a conceptual and a theoretical framework, and it provides for practices that affect assignment to patients and interventions that reflect an underlying philosophy of care. So it's that systematic, informed process of care to oversee care delivery. And there's a gap in the sorts of care that meets multimorbidity people at the moment, because what we currently have are models of care that are designed to meet a single disease condition. And unless you'd picked it up by now, I come from the acute health sector and I work in the ambulatory or outpatient area. And so the clinics are all designed for diabetes, respiratory, cardiac, dermatology. They're really single disease focused, and these are not suitable for people who are living with multimorbidity. So these current models of care are inadequate, and multimorbidity for people and for the health system poses a twofold burden. Firstly and foremost, it's a real burden for people in managing their own care in terms of time, emotion, physicality, pharmacology, family relationships, just a whole series of things. A consumer, a friend sent me recently an article regarding the burden of care, and it was a patient-reported map of the burden of care on themselves and on society, and it was just this massive, fragmented octopus with sort of like 200 tentacles going out for all the different areas that multimorbidity gets into a person's life. So it's very complex. So it affects people, and of course it's also a burden to society in terms of financial cost on healthcare budgets and other sorts of things. And as well as those patient drivers for new models of care, politically and policy-wise, there are agendas calling for new models of care. So therefore you can see that this single disease model of care is not meeting these complex patients' needs. We need a new model of care, a nurse-led, collaborative, coordinated model of care. And I'll go on to talk about that a little bit more. There is a definition there by Wong and Chung, and there are a couple of other definitions within the literature as well. I'll let you follow that up if you want to. But for the moment, so where I'm doing my research is situated within a multimorbidity ambulatory consulting service. And this service was piloted in 2015, and instead of the patient going to all those single individual clinics, as we have depicted here. So you can see that there's the patient, and then there's the respiratory, the cardiac, there's the investigations, the diagnosis, the appointments. You can easily see how a person's life and quality and relationships all just revolve around their chronic disease management. And it's not coordinated, and it's not the best sort of system for the patient. So out of those single diseases came this MAX model of care, and this is the new model of care, which is meant to have the person at the centre, and then outside of that is that person comes in to the clinic, and then the specialist, the nurse, the OT, the physio, the physician, the pharmacist all come and see that patient at the multimorbidity ambulatory consulting service. And you can see there that except for two things, so I think the medical management and the pain management are really medical issues, and the rest of those things such as nutrition, mobility, exercise, function, all of those other sorts of things are all what? They're all issues. Who would address those? Really nurses or allied health. Only two of them are medical. So this is the MAX multi-D approach that we are meant to be working in at the moment, or what was intended. Yet, even with the introduction of this new model, really the medical care still predominated, and the nurses were not attending to these things, and the allied health were not attending to them either. I've been working in that unit for about 15 or 16 months now, just very slowly. Last year was really just about building rapport, getting to know the staff, building trust, getting to see their operations and things like that. And because this is an action-based project, all of those sorts of things have been necessary. And what has come out is that the nurses' work is invisible. Their assessment was just tick boxes and summary sentences, and they didn't have a systematic, documented, explicit approach to assessment and care planning, and there were definitely no KPIs or evaluation measurements about the care that they did. So at this point, this is where I want to just link back to what Susan was saying, it was just such a huge leap to introduce a nurse-led clinic there, because really the way they had been working was really quite hidden. So what we needed to do to start off with is just simply make that nursing work explicit. So the systematic review that I'm going to touch on in a minute is really about finding new ways of practicing and making nursing explicit, and ensuring that the interventions, the structures, the processes, and that the outcomes in the new nurse-led care coordination service is strongly evidence-informed. So one of the things that's also happened, because I interact and we meet with the multi-D team weekly, and they're aware of the research of what's going on, and they're very supportive, as well as the nurses, but the term nurse-led clinic, they just don't see how that works when it's a multi-D clinic, and I think everybody's fair enough in that. So the term that people have agreed on is nurse-led care coordination service. So I still want to keep the nurse-led in there, but and it really is a service, but I think it's probably a conversation around nurse-led clinics that we are having at the moment. That's why I found the collaborative interesting. Care navigation, all of those sorts of things seem to be more acceptable. Okay. So what we know is effective is that they are, as far as nurse-led clinics go, already we know that they're efficient, that they do, in some instances, reduce hospital readmission. There's mixed evaluation as far as their economic viability goes, and they certainly do demonstrate feasibility in a range of nursing interventions. So as we can see, nurse-led clinics are feasible. There is a new model of care that's required, and the systematic review is going to be done to inform that new model of care partly. So the systematic review that Oh, sorry, it's just not gone. There we go. Sorry. So the systematic review that I'll be doing or have I'm reporting on is registered with Prospero, and it's really about addressing that gap in nurse-led clinics and continuity of care. And the types of participants that we'll be using are registered nurses, specialist nurses, clinical nurses, advanced practice nurses, nurse practitioners, and adults with chronic disease. And the sorts of intervention will really be focusing on continuity of care, relationship, management, and information aspects of continuity of care. And there are a number of tools and studies that particularly talk about continuity of care, and I'll be using a tool to collect data that relates to that later on in my research as well. And the context is going to be in ambulatory settings and also in the primary healthcare setting. So I will be having a stakeholder forum to engage GPs and practice nurses so that when patients are admitted to a clinic, there will be liaison with the GP services. And the search strategy for the systematic review will be a standard 3-step search strategy, really. And the PRISMA diagram, just to summarise the search and what I found. So originally there were 17,000 articles identified from 6 different databases, and I've drilled that down to about 22 at the moment, but I haven't done the final critical appraisal just yet. So the preliminary findings so far are that what we know so far, apart from continuity of care, is that nurse-led clinics are correlated with improved health outcomes, patient-centred care and positive patient outcomes. And we know, for example, that wound clinics such as Lorimer's in Canada provides continuity of care, and we also know that continuity of care in turn is correlated with improved health outcomes, positive patient experiences. And so following on from that, Jeff's article found that 5 of the highest ranked interventions associated with continuity of care were, no surprise, all of these sorts of things that practice nurses do, such as educating, coaching, that motivational interviewing. The communication is really important. Patients rank it as number 1, that you understand their individual needs and can feed back to them what it is, and that you do that joint work together. Standardised documentation tools and comprehensive communication strategies during care transitions. We've identified touch points within our clinic, for example, prior to patients' admission, optimising their care, getting ready for discharge to GP practices. They're all touch points that nurses need to be aware of, and the literature supports that if you want to get continuity of care for these patients. And then, of course, all the cultural things such as leadership and strategic alignment and accountability for structures and organisations, all of those things that are in the building blocks there. Okay, so the sorts of things that are associated with transitions, another term for continuity of care, are the case management and the care coordination. And the consistency of experience is also very important for patients. So in summary, the current predominant model of care is not satisfactory. There are particular nursing interventions associated with continuity of care and nurse-led clinics, and preliminary results do indicate that nurse-led clinics can demonstrate continuity of care. However, further research on this is required. And I've just got a picture up there of 2 of the people who are in the clinic, 2 of the nurses that I'm working with. I can talk more about that if anybody wants. And I really wanted to acknowledge, as well as the people up there, Julie Marker and Anne Bartlett, who are both consumers and have shared their stories regarding multimorbidity and informed my work so far. Thank you for your time.